This is the MyHeart.net podcast. This show is produced by Dr. Philip Johnson in conjunction with VitalEngine.com. Please welcome your host, Dr. Alain Bouchard, cardiologist at UAB St. Vincent's.
Welcome to MyHeart.net, and today we're going to talk about the next frontier in peripheral artery disease treatment, or PAD. And with us today, we have Dr. Chris DeGroat, who's a cardiologist at the UAB St. Vincent facility, one of my good friend and partner, well-trained at the University of Florida with Dr. Angiolillo. And so, Chris, thanks for taking the time this afternoon and talk a little bit about PAD.
Thank you, Elaine. I appreciate you having me here. It's certainly something I'm very passionate about.
Yeah, that's for sure. Well, when we talk about arteriosclerosis, we think mostly of a coronary disease and patients needing stents or bypass. We think about, heart attack. We think about stroke, but we don't talk too frequently about PAD or peripheral arterial disease. We know it's a major concern. We have about 88 million people in the U.S. with PAD, and it seems to be increasing by age. It seems like the older we get, the more common it gets, so that when we get in our 75 to 80 years old, we have about 20% of the population that have PAD. So, Chris, explain to us a little bit in simple terms, what's PAD and how does it differ from CAD or coronary disease?
So essentially, PAD is poor blood flow to your extremities. We mostly think of it in the legs as far as peripheral arterial disease, although it's carotid, the neck vessels, arm vessels, and leg vessels. But mostly we're going to focus on the leg vessels here. And essentially, it is poor blood flow from your heart to your feet. And it can manifest in various different ways, from leg pain and cramping to wounds and foots, and ultimately can lead to amputation. And when we talk about those kind of things, that has up to a 70% mortality at 2 to 5 years. And so it's certainly a very serious disease that honestly is probably very underdiagnosed and treated as a whole.
Yeah, I mean, it's really incredible. I mean, about 50% of the patients are asymptomatic, and maybe 10% of these patients have typical claudication, that pain in the leg. But, I think the reason that you gave that, I think probably triples your cardiac mortality, having PAD does matter, doesn't it?
Certainly, like you just said, if you look at some of the larger studies, if somebody has multi-vessel atherosclerotic disease, so coronary disease, strokes, and PAD, their mortality rate is extremely high. And like all diseases, PAD can be treated very well with either medical therapy or just good life modification. So we're not always talking about surgeries or intervention, but there's certainly things that we can do to reduce our risk tremendously.
Right. How do you diagnose PAD, Chris, in the office?
So I would say, as far as number one, is a good history. Like anything else, I mean, just a good history of how far can we walk and what really limits us. In my practice, a lot of times I hear neuropathy, 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 and a lot of times it's not neuropathy. It's that I have true claudication. And so first is getting a good history. How far can we walk and what are our true symptoms? Is it really knee and a musculoskeletal issue? Is it cramping and pain in the legs? Two is a good physical exam. So not only taking femoral pulses, so groin pulses and popliteal behind the knee, but feeling the feet. There's things like loss of hair, skin texture, looking at the toes in between each toes, making sure there's no wounds or sores. And so for me, it's always good, a good history and physical. Secondly, something as simple as what is called an ABI, which is blood pressures in the arms and legs, is really a great testing tool that you can do at a primary care doctor or at a cardiology office anywhere. It's kind of a good screening tool. And then there's things like arterial ultrasounds, which actually look at the blood flow and the velocities, whether it's with exercise or at rest. So various different modalities. But I would say number one starts with a good history and physical.
Yeah. So that simple ABI that you talk about, I mean, of course, normally the blood pressure should be the same in your arms as it is, in your lower extremity. So normal, I guess, the ratio of 1. And what do you consider abnormal?
So anything for us less than 0.9 is technically abnormal. And really, when we start getting to 0.9, really should strongly focus on risk factor modification. Number one, stop smoking, exercise as much as we can, and walking, losing weight. Once we get, for me, below 0.6, 0.5, and now we're really talking about potentially leading towards critical limb ischemia and things like that. On the other side, especially as Lane, and a lot of these people with end-stage renal disease and calcified vessels, kind of the reverse too. For some of these people you see with 1.3 or extremely higher blood pressures in the legs and the arm is also a warning sign that maybe they have really calcified vessels and you're getting false readings. So, but just in general, if you're at zero point 0.9 and less, it's certainly diagnosis of peripheral arterial disease.
Sounds good. You start mentioning a little bit some of the first steps in the treating PAD, and you talked about a healthy lifestyle. Can you expand a little bit on that? You talk about smoking and walking exercise.
Yeah, I would say by far number one, if you're a smoker, we got to quit. Unfortunately, in my practice, sometimes I see wounds and feet sores and things that I got to look at patients in the eyes and have an honest conversation. What's more important to you, the smoking or your feet or your toes? So number one is smoking and even just reducing your smoking. Certainly, I'd love you to stop smoking, but even every cigarette less will help prevent peripheral arterial disease, even more than coronary disease. Peripheral arterial disease is associated with smoking. Number two is just simple activity. I mean, I'd love for all my patients to be at the gym and walking 5Ks, but it's simple things like I'm going to go with my spouse to the grocery store and walk around and do my normal activities every day. And so it doesn't necessarily have to be, I go to the gym for 20 minutes, but I go to the grocery store, I walk the full grocery store and instead of taking the cart, I park a little farther away. And so as much activity as possible with peripheral disease, really, even people with severe peripheral arterial disease, walking is one, two, and three to help with blood flow to lower extremities.
Is it safe to walk through pain?
Yes, even more than heart artery disease, we talk about walking through. There's oodles of studies that walking through the pain as much as you can tolerate, stopping and rest, and then keeping on going, because essentially your vessels are trying to grow collaterals and get larger through walking. So yes, with peripheral artery disease, walking through leg pain is actually beneficial.
Of course, we've got all the cholesterol medicine, make sure their diabetes is well controlled, and walking and exercise certainly will work with the weight and the problem we have with obesity. Let's talk about medication a little bit. What are the medications that we have, for patients with PAD, Chris? What's our kind of first go-to?
Yeah, so I will say that again, unlike coronary disease, peripheral disease is still to me a part of vascular cardiology or vascular medicine in general that has a lot of growth to do. So number one is some kind of antiplatelet regimen, whether it's aspirin or Plavix or a medicine called pedal or salocazole. Although salocazole in general has shown some benefit in walking distance, but um, never really for people with critical ischemia. But so number one is antiplatelet. Number two is certainly like you discussed, lipid management, trying to get your cholesterol less than 100 and close to 70. Diabetes is by far one of the other huge things at A1C less than 7. And luckily nowadays, and one of the things I'm part of a research study, we're part of a research study now is not only there's a lot of diabetes medicines, but good for other reasons, not only good for glycemic control, but how is it good for your heart or peripheral arterial disease or weight management? Um, so medicines like that, and certainly losing weight not only helps in the joints and everything else, but now we know more and more about inflammation and everything else with the weight loss, which is, Elaine, as you know, weight loss for me is a very thing close to my heart and something that not only makes you feel better, but clinically make you live longer.
100%. You know what? My daughter, she's a nurse practitioner in California, and last year we went to the ACC in Chicago, and kind of went to the presentation of Stride, which was first time that someone was testing GLP-1 receptor agonist medication was actually Wegovy. No, actually, I'm sorry, I think it was Ozempic, in diabetic patient. And we were just stunned by, some of the results that they obtained. You want to expand a little bit on the STRIDE study?
Yeah, so the STRIDE study, I don't have the details in front of me, but just GLP-1s in general certainly came out for diabetes and to start with, and then the weight loss benefit, depending on which one you look, 15 to 25%. And then they had the SELECT trial with the Ozempic, which showed a roughly 20% reduction in cardiovascular benefits. The FLOW trial with the benefits of kidneys, and now there's the fatty liver trials. And so we've seen other benefits with these GLP-1s and their benefits besides the diabetes and weight loss. And that is, to me, and one of the bigger fields coming along with these GLP-1s and especially the GLP-1s and IP-1s, which are a combination, which have shown tremendous benefits.
Yeah, I mean, how do you think it's kind of a lowering of the inflammation, or just kind of improving some of the small vessel? I mean, these patients could walk much better, improve the quality of life and their walking distance. I was, stunned.
Yeah, and that's really the big question now. Certainly, we know that people that lose 20% of their body weight, they're walking farther just because of the reduced weight and the joint and the stress and everything like that. But there's more and more mounting evidence of the decrease of inflammation, which is helping some endothelial activity within the arterioles and helping with blood flow with the inflammation, like you spoke of. And so I think it's actually probably a combination of both of them. Not only are you just reducing the weight and joint pressure and strain and everything like that, but you're actually having some effect on the actual arterial and the endothelium of the vessels, which is actually improving flow. So we're hoping it's a combination of both. There's always been that debate with some of these other things like the flow trial and the select trial about the cardiovascular benefits. Is it all just the weight loss or is it everything else? And I think it's starting to look more and more like it's a combination of both of them and not just purely the weight loss.
Well, you have a very interesting study coming on later this year, to study one of those GLP-1, and it's actually a pill. And I don't know if I'm going to say the name right, but I think it sounds more like something like orforglipron, which is a medication that you're going to be testing in patients with PAD. Can you tell us a little bit about that, even though you haven't started the study yet?
Yeah, so you did a tremendous job with the pronunciation, probably better than I could. But it's the ATTAIN PAD study, and essentially it's for people with stable peripheral arterial disease. So it's not the people with critical limb ischemia, but people with overweight and really either whether it's mildly overweight or weight or significantly overweight who, when they get walking, they start to have symptoms and claudication and pain in their legs. And how much does it help these people not only walk farther and quality of life? So that is going to kind of be the main primary outcome of how can we improve your functional capacity. And as you know, one of the number one predictors of how well you do in life is your functional capacity. So if we can improve that, whether it's for peripheral disease or coronary disease or whatever it may be. And so that is really the primary endpoint. But there's going to be secondary endpoints of A1C and decrease in inflammation and weight loss. And so it'll really give us a lot of information of not only just does this improve clinically people with peripheral arterial disease being able to walk farther, we'll also see what is the weight loss, what is their inflammation markers, what is their ABIs, and different things throughout the study.
Yeah, really exciting. I can't wait for you to be starting the study. I mean, all you need is PAD with an ABI of less than 0.9 and, symptoms of claudication. And it doesn't seem to matter what weight you are. I mean, you could be just a BMI of normal BMI, which is very interesting.
Correct. And you and I have talked about this, really the BMI of 23, which, I mean, nowadays, especially in our state, Alabama, and then all over, a BMI of 23 and above is pretty commonplace. And so I agree. It's a really study of kind of, it's not truly an all-comer study, but it is pretty much open to everyone and see how they react to the medication.
Do you think we could reverse PAD, or is this something that is always going to get worse?
I I think that people can live with PAD even with the diagnosis. I have people now that have complete occlusions of their lower extremities who live their life and who actually kind of follow the regimen and quit smoking and start a walking regimen. So do they get rid of it? No, but do they live a normal, healthy life and do well? Yes. And I think this is another tool to help them. Are we going to eradicate PAD? Unlikely, unfortunately, in America. But if we can get it to where, yes, I have PAD, but at 100 years old, I'm doing what I want and I have PAD, but I've managed it medically without surgery or any kind of procedure, that would be the perfect world, I think, for everyone.
What's your takeaways for patients with PAD today?
I think that PAD is a growing field. I mean, in PAD is something when I came out of training, I thought I was slightly going to be part of, but I saw a patient early in my career that I sent for a possible surgical procedure, get an amputation, and unfortunately passed away within a year. And I started looking at the information and seeing how high risk the mortality is, and I've learned more and more about it. And I tell patients all the time that we are still learning a ton about PAD, and we do not have a great surgical or interventional thing that is a super long-term intervention. So number one, two, and three should still be medical therapy, but I do think that we're getting better and better at it. And I think that this is a team thing. What I tell patients all the time, I'm in it with you, but you got to be in it with me. And so we got to walk, you got to communicate, we got to work on the weight loss and smoking and give them all the tools we can to do all these things. And I'm hoping with one of the new studies that we talked about, that is another tool that we can use that, yes, I have peripheral arterial disease, but I get to see my grandkids play softball every day. I get to go to the gym. I get to enjoy my life, and it's just really no. It's something I have, but I'm able to live a normal life. Is kind of my hope for these people.
All right, folks, if you have PAD, you better look him up. Chris DeGroat at the UAB St. Vincent, and also later on this year, at the UAB St. Vincent Clinical Research, you can go on the website or give him a call. Thank you, Chris, for your time today. Appreciate it.
Thank you, Alain.
To learn more from our team of cardiologists, please visit us at MyHeart.net. You can also follow us on social media by searching MyHeart.net on Facebook and Twitter. And be sure to subscribe to this podcast so you don't miss our next episode.